Sorry, yeah. Good morning, everyone. I think we'll get started. It's a real pleasure this morning to have this combined anesthesia surgery grand rounds. Thanks, anesthesia, partner Dr. Thiele for sort of suggesting Dr. Rosengart to come. But it's really a real pleasure to introduce our grand round speaker today, Dr. Matthew Rosengart. So Dr. Rosengart, he's a professor of surgery and the Theodore and Bertha Bryan Professor of Environmental Medicine at WashU in St. Louis. He's internationally recognized leader in trauma and surgical critical care. His research really focuses on the biology of sepsis, calcium signaling, and sort of the interface of sort of circadian rhythm and critical illness. His work has been continuously funded throughout the years by the NIH. He's highly cited, and more importantly, he's helped shape many of us the way we think about critical illness. So before his move to WashU, Dr. Rosengart spent many years at the University of Pittsburgh. There he served as a vice chair for academic advancement, directed the Surgical Critical Care Fellowship, and mentored an extraordinary number of trainees who are now leaders in the field. His impact as a mentor is every bit as notable as his scientific contributions. On a personal note, Matt and I, we go way back together at a time at University of Pittsburgh. That was a period when we were both starting our early careers. It was great to have a colleague and a friend like Matt. We worked closely together. We helped each other out. We collaborated on projects, shared ideas, and really just, we had to go through the ups and downs that many of us face, starting a career in academic medicine. He was really instrumental in really helping my research career, especially with his expertise in calcium signaling. And I can still remember the many early mornings and nights when we were doing the cecal ligation and puncture for his abdominal sepsis experiments. So for all the trainees in this room, Dr. Rosengart's career is really a great example of asking, thoughtful questions and having the courage to see how you can answer that and really impact and move the field forward. So Matt is not just an outstanding physician scientist. He's one of the smartest, most thoughtful, and most caring individuals I have known. And I'm grateful to also call him a close friend. So please welcome Dr. Rosengart.
Morning. Can you hear me? I tend to sort of stroll around a little bit as the anesthesiology resident. So if I get too far from the mic, let me know. Or if I get too close to the mic, let me know. It really is an honor to speak to you today. Just a couple of disclosures. I am indebted to Dr. Sung, Dr. Thiele, and members of the Department of Surgery and Anesthesia for inviting me here. Glorious campus, wonderful institution with a strong historical background in surgery and healthcare. And importantly, this talk, though it's about science, I hope you're able to hear on a much higher level a little bit of a transcendental message to the house staff, and that is one of dreams. I don't think wiser words could have been spoken. I'm standing in mine. Nearly 30 years ago, I'd be occupying one of those seats over there as an intern. And now I am speaking to the house staff. You're gazing out no differently than I was back then, trying to see your future, your dreams. To a certain extent, we all are. And you have the good fortune of a splendid cadre of admirals to give testimony to the bounty of really being true to oneself and pursuing one's dreams, knowing that you will. I met Dr. Sung, or if I may call him Alan, over the inguinal canal of a mailman back in 2004, right? He had been shot, the mailman that is, and I was faculty and he was a PGY3. Is that right? I think a PGY3. And as we both hung our heads over the expanding hematoma of the left inguinal region, I certainly didn't know what to do. Thank God Alan did. What blossomed from that initial encounter really has been nothing less than miraculous, right? We begin to talk and get to know each other and share our attitudes, values, and beliefs. We ultimately began catalyzing our practical worlds, our labs. As Alan said, he'd come over and help me with my CLP model. I'd go over and help him with his models. But that rich experience began to expand outside the laboratory into the operating room where we'd help each other in cases. And more importantly, it expanded outside the walls of the lab, operating room, and hospital into the lives of each of us. And I've had the distinct pleasure of getting to know him and watching his family, Eva, Peter, and Caroline, grow up. And for that, I am forever grateful. As I said before, this is a talk about science, but there's going to be a talk or a message at a higher level, so do try to pay attention. They say in medicine that we should look, listen, and feel. And we do it swimmingly well in the practice of our craft, right? We look and listen in doing a physical examination and taking a history and making diagnoses. We certainly feel when we're in the operating room and practicing our craft. But I encourage you to hone over time a certain sagacity, a wisdom, an ability to see what might not initially be present to the naked eye. To listen and hear what's between the spoken words and certainly the written line, and importantly, to feel yourself in the presence of others. This story you're going to hear today begins back in 2008. So I'd been on staff for about 4 years. And I was introduced to this individual, Ricardo Castro. He's an anesthesiologist from Santiago, Chile. And he came to the University of Pittsburgh because he wanted to do a critical care fellowship and also get a master's in public health. And he needed a mentor. He needed a mentor to guide that project and to be on his thesis committee. And I had an MPH, and we were paired together. And what I came to appreciate as we began talking is that Ricardo is a genuinely wonderful individual. And he is indebted to his family, in particular his mom, for investing in him and getting him to where he was today. And he wanted to study whether or not the smell of the home improved outcomes from the ICU. In fact, he wanted to study whether or not the smell of mom, if you bring it in to the bedside, makes outcomes better. And I thought to myself, well, that's sort of an obvious truth, right? Since the dawn of time, the idea that mom makes things better, you can add mom to any sentence, and all of a sudden it becomes better. It comes good connotations, right? Like mama used to say, like mommy used to cook. And so we ultimately decided to study light. And we went to the library, which is what I typically do when I begin a project that I'm really not certain I have sufficient expertise. We began to read. We began to learn that mammalian activity, our foraging, our feeding, exhibit a temporal pattern. And that temporal pattern is imposed, if you will, by the solar day and calendar. And with that, so too is the likelihood of encountering threats to our existence, such as infections or trauma, and the metabolic demands that are inherent to life itself. As I awake and forage for food, as I run around during my active day and my confectionery delight plops onto the dirty sidewalk and I, unfazed, pick it up, put it back on the cone, and go on eating, I get a pretty large inoculum of bacteria. And as I run around by the seashore with Sally and I scrape my knees on seashells, I again incur the insult of trauma, bleeding, as well as a significant microbial threat. And so, in fact, the threats to our existence exhibit this temporality, and it is almost to be expected then that life would prepare for these risks. Excuse me. And those risks occur during the day. Now, the flip side is that it's energetically expensive to maintain any tightened state of preparation. And so those risks go away at night, and there's a selection pressure to prepare for this reduced risk. And that for us is at night a period of rest. So what does evolution do? Louis Pasteur says chance favors a prepared mind. Evolution hates taking chances, and she loves the prepared mind. So she was ultimately able to link these two processes, rise and the fall of the sun, and the risks to our life, trauma, and infection. And from that, selective pressure emerges elegant biological clock that serves to prepare us for the active phase and its inherent threats. And the dominant environmental cue is light. So all mammals perceive visible light in the spectrum of about 400 to 700 nanometers. The gateway is the eye, and two functionally distinct mechanisms emerge, right? There's the visual pathway, right? Light comes in, goes through the lens, hits the rods and cones of our retina, goes through the visual and optic nerve to the visual cortex, and enables you to perceive the world around you. And undoubtedly, that provides an immense selective pressure benefit. But there's a non-visual pathway. There's a pathway that essentially enters the eye, hits a third type of ganglion cell in the retina, an intrinsic retinal ganglion cell, passes through the retinal hypothalamic pathway, onto the suprachiasmatic nucleus, and from there signals go to the pineal gland, the hypothalamic pituitary adrenal axis, and the superior cervical ganglion and vagus nerve, or autonomic nervous system. And it's through this non-visual pathway that the dimensions of light modify all the biology in our cells as multicellular organisms, and in particular immunity. In fact, every facet of immunity exhibits a circadian phasicity. Now, I'm not going to go into this in too much detail, but I think having a little bit of an appreciation for this autonomous transcription translation feedback loop that garnered the Nobel Prize recently will help ground you or enable you to understand the content of this a little bit. So there are some core proteins, B, mal, and clock. They come into promoters and induce the transcription and translation of a whole host of proteins, two of which are themselves, but two, period and cryptochrome, are translated and go into the nucleus and displace B, mal, and clock, thereby shutting the system down. But over time, period and cre are degraded. They're released essentially from the nucleus. Those promoter regions are freed back up, and B, mal, and clock can come back in and bind again and set the cycle anew. And this central biological clock of the SCN possesses a 24-hour periodicity, and its dominant environmental cue is light. Now, there are peripheral tissues and there are peripheral clocks, and they also exhibit circadian oscillations. In fact, if you took any cell out of your body, the exact same transcription translation feedback loop would exist in it. And these have demonstrable roles in regulating these tissues' phenotypic function. So in the adrenal, this clock does adrenally type of things. And in the kidney, this clock does a kidney type of things. And the same thing with regards to the marrow and the liver and the spleen. But it's the SCN that keeps these peripheral tissue clocks in harmony with each other. Via the pineal gland, the hypothalamic pituitary adrenal axis, and the autonomic nervous system, their respective hormones, melatonin, glucocorticoids, catecholamines, act as synchronizing messengers, if you will. Zeitgebers to peripheral tissues, and this keeps them in phase with each other, and this synchrony allows for the coordination of a temporal program of physiology across many tissues at certain times of the day. And immunologically, this manifests as an increase in chemoattractants and leukocytes and inflammatory cytokines during the period of the hours before we wake up. For us, that's in the hours before the sun comes up. For rodents, it's before the sun goes down. So on a daily basis, there's this entrainment of leukocytes out of the bone marrow into the tissues, and this alters the susceptibility to infectious threat. Immune competence for us becomes highest just as we're about to wake. We're able to clear Listeria monocytogenes, streptococcal, and salmonella organisms, which was far better in those early morning hours for mice, that would be at night, than at periods of night for us. In fact, you can notice that most of the organisms we're able to clear are things that we would ingest. There's increased leukocytes in all of the tissues, the GI tract, the lung, essentially patrolling and providing enhanced immune surveillance as we wake and encounter those threats. There's also greater induction of pro-inflammatory cytokines to non-infectious stimuli, right? So LPS, trauma, might cause a little bit of an exacerbation in the degree of inflammation. But even at the cellular level, there are profound changes that occur. In fact, our macrophages, their mitochondrial biology wakes up in the morning, and they're able to phagocytose much better in the morning hours than when we're sleeping at night. And all of this is thought to be enhanced immunosurveillance at a time when those infectious risks are maximal. Now, I'm speaking to surgeons and clinicians in the room, so I don't want this just to be about immunity. There are other things that go up as we are about to wake in the morning, such as thrombosis and hemostasis, right? So there is a risk of trauma as we're trying to run away from a Tyrannosaurus Rex or things of that nature. So almost every factor within the coagulation system, the extrinsic, the intrinsic, and the common pathways starts to peak in the morning hours. There's an inhibition of fibrinolysis. We just make clot better in the morning, and that all wanes as the evening starts to approach. Now, why is this important? Well, there's a wenness to when we get sick. For over 3 decades, we've known that the incidence of non-fatal acute myocardial infarction peaks in the morning hours, somewhere around 8 or 9 a.m. And in fact, 3 decades later, we see the same temporal pattern of this thrombotic and inflammatory disease. Many propose that this is due to some of the things I spoke about before, right? Enhanced immunity, enhanced inflammation, maybe a slight predilection for thrombosis. But there's also a wenness to when we provide healthcare, right? Who here wants to first start OR? We'll elbow each other and knife each other to get it, right? But maybe that's not right for the patient. Maybe there is an ideal time to incur or impose healthcare upon the patient. This is a really lovely study that came out in Lancet looking at the timing of cardiac surgery and the risk of adverse myocardial injury. Most of these patients were valves. Their definition of adverse cardiac outcome is depressed myocardial function, arrhythmias, perioperative myocardial infarctions, and things of that nature. It was a really, really nice propensity risk-adjusted analysis, almost 300 individuals in each group. And they looked at afternoon versus the morning. And what they saw was that if you had your operation in the evening, right, when that inflammation and immunity is waning, when your thrombotic state is waning and you're becoming maybe a little bit less clotty, that you had a reduced risk of adverse cardiac events than if you had your operation in the morning. Now, in addition to a daily basis, there's also seasonal variations with regards to how light modifies your biology, right? In the winter, we're sort of experiencing it now. It's cold. And there's a stress with regards to thermoregulation. Before we made houses and had grocery stores, we'd have to get our own food. And in the wintertime, there's a scarcity of nutrients. Not to mention that infectious threats also tend to cycle the globe with a periodicity, and those tend to peak in the wintertime as well. Little sense in having babies and a whole bunch of mouths to feed if you yourself don't know if you're going to survive. And so we undergo a physiology as well, or I should say mammals do. It's called photoperiodism. It's a physiologic reaction of organisms to the length of day or night. So photoperiod is the day, but implicit with that definition is the duration of night. And melatonin is only secreted when it's dark out, right? When it gets to what's called less than 5 lux. Lux is a parameter of the brightness of light perceived by the human eye. 1 lux is about the moon. If it's not less than 5 lux, melatonin doesn't get released. And so as the days become shorter and shorter and shorter, as winter approaches, mammals subconsciously pay attention to that shortening and undergo this physiologic change where energetic resources are diverted away from reproduction towards immunity. So in rodents, the testes shrink, the ovaries shrink, the thymus gets larger. You'll see extramedullary hematopoiesis in the liver. And if you inoculate animals after being harbored in short days, they clear bacteria much better. And they do it more efficiently. They don't even get a fever, and they really make very, very few cytokines. So there is this enhanced ability to deal with the threats when the threats are peaking during the wintertime, and this all reverts in the summer. So it's this that we decided to study, getting back to Ricardo. We decided to study whether or not photoperiodism occurs in human beings, and it hadn't been tested before. Most of the studies had been in nocturnal individuals. But how do you do this, right? How do you go ahead and get data on the light your ICU patients are exposed to before they come into the ICU, their photoperiod in particular, as well as the brightness? Well, I learned from Ricardo the bounty that comes from perseverance, and something that I've come to appreciate all throughout my career is the importance of being confident in ourselves, because our question was a little bit odd. So we wanted to know whether or not photoperiodism exists in humans, and we struggled and struggled and struggled until one day Ricardo said, you know what? And picked up the phone and called NASA. And lo and behold, on the other end, someone answered. And in a few days, we had a wealth of data on the duration of the day and how bright that light was for every patient that had come into our intensive care unit, based upon the latitude and longitude of the residence of their house. And we link those two data. And so what you can see here is that, yeah, the days are longer in the summer than they are in the winter. This is the photoperiod, duration of day. And the amount of radiant energy that hits their home is more in the summer and more in the winter. And we link these two data sets together and adjusted for all the things we possibly could. And lo and behold, it seemed to be the case that yes, in humans, as the days are getting shorter and shorter, your likelihood of surviving your hospitalization in the intensive care unit improves. So over here is just a time to death. It's the odds ratio of mortality. Cumulative photoperiod is getting shorter, so it's a little bit flipped. So as the days are getting shorter, the cumulative photoperiod to which you're exposed goes down, and you can see that the risk of death goes down. And if you look at it in a numerical tabular form, which is shown over here, those exposed to the longest day have a higher likelihood of dying than those exposed to the shortest day. And this got us really, really, really fascinated with this idea of light in critical illness. We were really, really fascinated by the results. But what we found to be more perplexing was the number of studies that we came across that had studied light in the ICU and failed to identify an association with outcomes. Outcomes we would consider to be clinically relevant, right? ICU length of stay, hospital length of stay, organ dysfunction, ventilatory-free days, and 28-day mortality. This is a study done by Hannah Wunsch. She's lovely up in Toronto, and she wanted to look at neurologic outcomes from individuals who had subarachnoid hemorrhage. It was a beautiful risk-adjusted analysis, almost 1,000 individuals, and she used windows as a surrogate marker for having natural light. Now, after adjusting for everything, at the end of the day, there was no association with the presence of a window in natural light and the outcomes of ICU and hospital length of stay, 28-day mortality, or ventilatory-free days. Scott Halpern did a much larger study of medical intensive care unit patients and surgical intensive care unit patients. There's almost 3,000 in each of these cohorts, beautifully adjusted for differences in case mix. And there was no association between natural lighting, presence of windows, and those outcomes I spoke of earlier. And a more recent study came out of Spain. And in this study, they actually quantified the amount of light that patients saw. They noted individuals were facing north, south, east, or west. If the bed was facing south, those individuals were exposed to about 500 lux, so reasonably bright. This is probably close to about 300 lux, okay? And the other one was quite low, about 100 lux, right? Now, as I said before, 1 lux is the moon. Less than 5 lux is needed to suppress melatonin, to release melatonin. Greater than 5 lux inhibits melatonin. You need about 500 to 1,000 lux to induce the HPA axis and get the release of corticosteroids. And we all know that about 10,000 lux is what those seasonal affective disorder lights are giving for the treatment of seasonal affective disorder depression. Okay? But this group noticed that at the end of their analysis, those individuals exposed to about 500 lux had similar outcomes to those that were exposed to much darker aspects of the ICU in terms of 28-day survival, hospital and ICU length of stay, organ dysfunction, need for renal replacement therapy, and ventilatory-free days. And we were perplexed. I mean, there's a whole bunch more studies, all of which were negative. And Ricardo and I thought about it for a while, and we came to appreciate that most of those studies, the intervention that was studied is passive, whatever gets into the ICU, right? And I think we all appreciate that what gets into the ICU or gets into the hospital is very different than what Mother Nature made for us, right? Light's complex. And I don't think that they incorporate that complexity into the design of their studies. So light exists in really 3 dimensions: illumination, the brightness, the intensity. As I told you before, we need about 1,000 lux to start getting some of the biological effects. We need less than 5 lux to get some of the biological effects, such as melatonin. There's a photoperiod. There's a time that the lights are on, and implicit with that, it's a time that the lights are off, and both are important to the biology. And lastly, spectrum. The cryptochromes in the back of our eye that activate those intrinsic retinal ganglion cells are maximally entrained by a wavelength around 460 nanometers. That's blue light, rich blue light. So Ricardo took a spec and went around to all the ICUs and measured the amount of light that was outside, inside, and at the bed. And what he saw is over here in this left-hand side, that on a sunny day in Pittsburgh, the illumination is about 120,000 lux. It's really, really bright. Even on a cloudy day, it's pretty bright, 50,000 lux. You get to the bed, you get to the window, you're down to about 2,000 lux. And when you get to the head of the bed in the ICU, 99.6% of the brightness has decayed. it's only about 200 lux, which is equivalent of a 15-watt incandescent light bulb sitting by your desktop. And I can think of no place where the lights are more perturbed than in the hospital, particularly in the intensive care unit. And other studies have shown the same thing. So this is a study that came out of California. They looked at the illumination at the ICU bed over a 24-hour period. And what you can see is that it never gets bright, right? Never gets about 140 lux. But it also never gets dark. Not once did it get to less than 5 lux. And so for all intents and purposes, our ICU patients are having an experience where the lights are really never on, but they're also never off. And when you step inside from Mother Nature, we're exposed to a very different spectrum of light. No longer is there this immense amount of rich blue light around 460 nanometers. You can see that our fluorescent bulbs, incandescent bulbs, and LED bulbs, though they have some shortwave blue light, it's very, very short, and that area around 460 to 450 is still missing. So Ricardo and I wanted to test whether or not an acute exposure to bright blue light would alter biology. And we pitched this to various members of the faculty, and most of them thought we were just crazy. But I couldn't forget the question, and I just couldn't ignore it. And I began thinking of this parable from Shel Silverstein that I used to read to my kids that I thought might be quite salient to the house staff that are in the room. All the woulda, coulda, shouldas laying in the sun, talking about the things they woulda, coulda, shoulda done, but those woulda, coulda, shouldas all ran away and hid from one little did. And I didn't want to hide, and I had the good fortune of a bunch of other individuals that didn't want to hide either, one of whom is sitting here in the second row, Dr. Allen. And so we decided to study whether or not acute exposure to high luminance blue spectrum light alters the biology of IR. And we chose IR because we thought that it was a little bit more mechanistically simple. I'm an immunologist. I love the host pathogen conflict, but I thought that the complexity to dive into that was a little bit premature. So we decided to study liver IR. And here again is where I reached out to the house staff and say, where there's a will, there's a really cool experiment you can do, right? I had no money. So I decided to BFF Jeff Bezos, and I bought 2 of these Carex health lights off of Amazon. I was $260 in the hole. And we chose these because these are the lights that were used in the original seasonal affective disorder studies for depression. And I went down to a local theater store, Vincent's Lighting, and I bought 2 filters, and I created essentially a poor man's circadian light experimental platform. You got mice that are in blue, you got mice that are in red, and the lighting that they're exposed to is shown here. So we took a spectrometer and measured the spectrum and the brightness, and you can see that one group is exposed to very, very bright red light, peak around 600 nanometers, illumination, 1700 lux, above that 1000 that we thought would induce pathways, one similarly bright, but mostly blue. And then we always include this bottom group here. And this bottom group essentially is what we're exposed to on a daily basis, only 300 lux. We decided to pre-treat the day before. There are some surgeries where you could pre-treat patients, right? Cardiopulmonary bypass, big liver resections. So we put the mice in blue, red, or ambient light the day before, and we subjected them to IR, and then we took out some blood and some tissues, and this is what we saw, that if the mouse had been in blue light the day before the model, there was a reduction in liver injury that was quite significant. About a 50% reduction in ALT concentrations. I think we're all familiar with the use of ALT to monitor liver injury in the intensive care unit and things of that nature. But when you took those tissues out and quantified the volume of necrosis, you see that animals that had been sitting in blue light the day before had a significant reduction in the amount of tissue that was necrosed from ischemia reperfusion. We were completely incredulous to this, and so we decided to jump into a completely different model. And this is a lesson well learned that, again, I direct mostly to the young investigators as well as the house staff, and that is that when you're testing a hypothesis, the more angles you can come at to test that hypothesis and come away with the same answer, the more likely it is that you're stepping closer to the truth. So we decided to repeat this IR model, but in the kidney. This is unilateral renal ischemia perfusion. We ligate one kidney, the other one serves as a control, but it is a completely different tissue. It is far more sensitive to ischemic injury, and it's a completely different anatomy and neural input. We treated animals the day before and then subjected them to ischemia perfusion. We saw the same thing. So on the left-hand side is cystatin C concentrations. It's sort of like creatinine, but a little bit better. It's neither secreted nor absorbed. You might be seeing it more in the ICUs because we're using it more and more to monitor renal recovery in individuals who are on CRT with acute kidney injury. But there's about a 50% reduction in animals that were exposed to blue light the day before than the other two lighting. And again, when you looked inside these tissues and quantified the amount of necrosis using a grading scale, you can see that mice exposed to blue light had reduced tubular necrosis and reduced glomerular sclerosis. Well, we're feeling our oats now, right? Getting a little bit giddy because we're constantly coming up with the same signal. And we decided to jump into the world of sepsis. And we took the same type of approach, right? Two different angles to ask the same question. And I had the good fortune of knowing these three individuals. Tony Lewis, he was a general surgeon at the time. He's now a vascular surgeon at UPMC. John Griepentrog, who's in the middle, also was a general surgeon. He's now a trauma surgeon at the University of Tennessee. And I have the good fortune of knowing the individual on my right for about the last 36 years. That's my wife. Janet Lee, she's chief of pulmonary medicine and critical care and a phenomenal molecular biologist. We studied CLP and we studied pneumonia. I think most people know about CLP. You know, I tie off your cecum, I punch a hole in it, let a little poop get into the abdomen. It's a model that's no longer used really too much because it's thought to be a little bit unrealistic, but we use it because it's a good model for the insult of polymicrobial sepsis and necrosis. We also sort of try to apply best practices. The next day we go in, we resect the segment, we go ahead and do an anastomosis, we wash things out, we close it up, and we give them 96 hours of antibiotics a la the stop it trial. The other model is Klebsiella pneumonia. This is a very, very virulent strain. It kills the organisms within, the organism within about 72 hours by widely disseminating. And what we've done now is asked the same or tested the same hypothesis, but again, two different portals of entry, two different immunologic niches, two different neural pathways, one polymicrobial and one monocrobial. What I'm showing here is the CLP. We measured how well the organism cleared bacteria by lavaging the peritoneal cavity and quantifying bacteria, as well as taking the blood and quantifying bacteremia. And you can see that if the mouse had been exposed to blue light, and I should add, in this model, we could not pre-treat. Right? It's rarely that patients come in thinking, you know what, I think I'm going to get really, really septic and the wheels are going to come off the cart, so pre-treat me. So we only treated the animals after, and we started at 4 hours after CLP or 4 hours after giving the Klebsiella pneumonia, thinking that that'd be a little bit more clinically relevant. Well, what you can see is that for the intra-abdominal sepsis model, mice that had been exposed to blue light after had about a log order reduction in colony-forming units in the abdomen, reduced bacteremia. Not surprisingly, that was associated with an attenuation in systemic cytokine concentrations like TNF, IL-6, and IL-10, and they were protected from getting acute kidney injury. We took a series of logical steps to sort of figure out how this occurs, and we ultimately identified an optic cholinergic pathway. So if I take mice that undergo optic nerve degeneration, no longer is blue light protected. The eyeball is important. That made us think that it's going into that central suprachiasmatic nucleus and down through one of those pathways, melatonin, glucocorticoids, or the autonomic nervous system. Well, interestingly, these mice don't make melatonin, so that proved not to be an issue. When we measured corticosteroid concentrations, we saw nice oscillations over a 24-hour period, regardless of whether the mice were in blue, red, or ambient white light. And that led us to consider that this must be through the autonomic nervous system, which is a little bit of a challenge to study. But at the time, I was also doing a project trying to make a mouse ICU. And we were implanting these little pellets into mice. They're about the size of a kernel of corn. And they let you monitor all the things that we were monitoring humans: ECG, invasive blood pressure, plasmography, oxygen saturation, core temperature, mobility and foraging, as well as continuous glucose. And we recognized that we had this electrophysiology data of the heart, and from that, we could model things called parameters of heart rate variability. You've probably all heard it. Well, the electrical activity of our heart has a variability to it, and it varies in the domain of frequency. It varies at a high frequency, and it varies at a low frequency. The parasympathetic system tends to affect the heart electrical activity very, very quickly, so it tends to have more of an effect on the high frequency. And the sympathetic system is slower, about 5 seconds or longer, and tends to affect the low frequency a bit more. And so you can look at the low frequency and the high frequency and gain an appreciation for what arm of the autonomic nervous system is dominant. So So we put these pellets into mice and exposed them to blue light or red light. And what we saw was a parasympathetic dominance if mice were exposed to blue light. Their heart rate slowed relative to red light. And we also saw those parameters of heart rate variability change in a manner that was indicative of parasympathetic dominance. We then inhibited the vagal efferent using alpha-bungar toxin, and we lost the effects of blue light. And in our models of sepsis, interestingly, if I take out the spleen, we lose the effects of blue light. Now, as I said, we had proceeded in a very logical manner, but I want to emphasize, and again, this is me reaching out to the house staff, that though it was logic that we ultimately used, that were the boots on the ground, logic was always held by the hand by imagination and led by imagination in pursuing this. And with the number of sort of positive hits we had received by then, we were really starting to dream, right? In fact, a little bit cuckoo. Some of the questions we had were quite inane. But one of them was, can I dial you in? Can I just change the spectrum of light on the wall and modify your autonomic physiology and your biology? And so we exposed a mouse in each one of these little boxes to a different spectrum of light that varied by about 50 or 100 nanometers. And we would come in at night when the lights had gone off, and we would rotate these films such that every single mouse had been exposed to every different one of these wavelengths when we had those parameters, those little monitors that were in them. And we binned that data ultimately by the spectrum of light and answered this question that indeed I can. So as the wavelength goes from long to short, the heart rate slows. If I do the reverse and make it short to long, the heart rate goes up. So you can essentially toggle your autonomic nervous system using light in the gateway of the eye. And when the lights go off, all of the animals coalesce to the same type of heart rate, 600 to 650 beats per minute. Well, that raises a question. What happens when you do this? Which some are. What happens when you do this at night? Okay, so question. What's this? Okay, anyone? What's this? Okay, so both are texting, okay? And this is actually the screen. Both are texting. But the top one, and if you notice, its peak is right at 460 nanometers, right? Perfectly telling you to wake up. That's if you just have it at daylight setting. If you put on that night shift, where it sort of takes a spectrum, you can see that, yeah, it takes away most of the shortwave blue light, but it's still present. Okay. So we were really, really interested on understanding the immune cell that regulates this. And it was a little bit of a challenge. And we ultimately decided to do something called single-cell RNA-seq to answer this. Single-cell RNA-seq was all the hot rage back then. Now I think omics is on everybody's tongue. Every other word is omics, omics, omics. But single-cell RNA-seq lets you barcode every single cell in the immune system, right? And then look inside that immune cell at the transcript, and you can identify various clusters, right? The cells form cliques. They want to be with some, they don't want to be with others, right? And so we decided to do single-cell RNA-seq on mice, the spleen, after KP and exposure to blue, red, or ambient white light, right? So this is 3 days later. And what we identified was that 10 clusters of B cells, and I'm only showing you the B cells, 10 clusters of B cells formed, right? And I want you to focus on two. I want you to focus on cluster 0, which is down here, and I want you to focus on cluster 2, which is up here. You can see that cluster 0 is dominant in mice exposed to blue and absent in red, and cluster 2 is dominant in red and absent in blue. And if you look at the transcriptome in these cluster 0 that are in blue sun, you'll see that they are for functions that we all would consider to be good for a B cell fighting an infection. Increase in MHC1 and MHC2 class expression. Increase in B cell receptor activation, binding, antigen binding, processing, and presentation in immunoglobulin production. Whereas this cluster that's dominant in red, and I don't show the transcript, is primarily inflammation, neutrophil recruitment, as well as apoptosis. Now that's just transcript. It doesn't necessarily have anything to do with function. And so we did take the serum from those mice and look at IgG concentrations, and you can see that indeed they're elevated. Now I don't want this talk to be all about rodent, right? We're diurnal. So what's the relevance of all of this to human beings? It was about this time that my department chair said, go speak with this guy. This guy was the department chair of ophthalmology at the University of Pittsburgh. So I went over to his office and we started talking about eyeballs and stuff like that. And I came away, having listened to between the words and the lines, a couple of things. Number one, that as we get older, some yellow crystalline deposits form in our lenses, right? And that impedes the transmission of light, but it does so disproportionately. It affects the short wavelength much more than it affects the long wavelength, such that when you get to about 70 to 80 years of age, only about 20% of that 460 is making it through. And in fact, if you develop really pathologic cataracts, that goes down to 0, right? And people usually develop bilateral cataract. So over time, there's a good chance that many of us no longer have blue light. Well, we have a solution for that, right? We can take those cataracts out and we can put in intraocular lenses. Well, lo and behold, message number 2 was that not all lenses are created equal. There's a clear lens, as you see on the left. It's a conventional lens. It lets in the entire visible spectrum all the way down to 400 nanometers. And there's this yellow lens that actually blocks the blue spectrum. And that emerged because of a concern that the higher energy of the blue wavelength light is injurious to the retina and causes an acceleration in age-related macular degeneration. Now, that has not proved to be true. But that made us realize that a small randomized controlled trial has already occurred for us. That there's a group of individuals that have bilateral cataracts, so they've got no blue light, and we either take those out and give them blue light back with the conventional IOLs, or we prevent blue light from continuing to be transmitted with those blue filtering IOL. So we went through the entire UPMC system to identify all the individuals who had undergone cataract surgery over 6 years, about 39,000 operations. And of that, 9,100 individuals had bilateral and concomitant cataract surgery, meaning that both eyes were operated on, and they were operated on within 180 days. And all of these lenses, these IOLs, have a serial number. And we pulled all the serial numbers so that we could ultimately trace it back to what type of lens it was. And we had 91 individuals that had bilateral implantation of IOLs that restored blue light, or bilateral implantation of blue filtering IOLs and still didn't have blue light. And we adjusted for everything. And at the end of the day, you can see that if I give you blue light back, there's an association with improved long-term survival. This got us even more believing in the idea that I can acutely modulate human biology with blue light. And so we began a series of studies, and this has been about the last maybe 2 years worth of work, on acutely exposing individuals to blue light at a time when you shouldn't be exposed to blue light. Why is that important? Well, I'm a trauma surgeon, or certainly used to be one. People come in typically at night. They usually bleed a lot. And I wanted to know whether or not I could change their ability for hemostasis and thrombosis, as well as immunity, right? And my overarching research paradigm is, can I make you the time of day that you're supposed to be based upon what you're going through or what you plan to go through? So we did the same thing with humans. We exposed them to blue or red light. You see, we've got this Italian runway model over here that's modeling the blue goggles, and you sat in front of the same seasonal effector disorder light. And we monitored your electrophysiology with this Holter monitor, and it comes with a nice program called Kubios, where I can measure all the same parameters. And what you can see is if one individual sits in front of blue light, there's this augmentation of parasympathetic tone and this removal of sympathetic tone. And if you sit in front of red light, that really doesn't occur to the same degree. And this is a short acute exposure. It's only 180 minutes. We took the B cells out of those human beings, right? And I should add that the exposure to light was between 8 p.m. and 9 p.m., right? So at 8 p.m., you come in, I take your blood, you sit either in the office or then are exposed to blue light, and I take your blood again 1 hour later. And every individual that sat under blue light also sat under ambient light at a later date. And so for all intents and purposes, these are pairs, right? What goes up in B cells after exposure to just the office lighting? Well, relatively little. None of these are actually statistically significant. Here's the sort of color scheme for what is statistically significant. Even these 5 red dots are not. So you sit in ambient white light, your B cells don't change. But if you sit in blue light for 45 minutes, everything that changes are the same things that we saw change in mice. Increase in MHC1 and 2, increase in immunoglobulin production, increase in antigen presentation and processing. But what goes down? Again, very, very little, in fact, almost nothing in the ambient white light group. But if they're exposed to a short period of blue light, it essentially attenuates inflammation, as we saw with the mice. Reduce chemokines, reduce cytokines, reduce neutrophil chemotaxis, and things of that nature. So it seemed that I could acutely expose you to blue light and really modify your biology. And we've begun to incrementally march this forward to more and more and more complex models. So we decided to take this to a model of appendicitis. People come in, they get their appendix out, they're a little bit inflamed, I can shine blue light on them. It's a young population, maybe they'll think this cool and will participate. That actually proved to be true. They thought the blue light was sort of cool. And I could get a sample of blood before you get your appendix out, then shine you with blue light or just the ambient white light of the hospital, and 18 hours later, get another sample of blue light. Now, if you recall before, if I did that to a mouse, you saw an attenuation in cytokine production. Reduced IL-6, reduced IL-10. And indeed, the same thing occurred in human subjects after appendectomy. So if you just were in the regular hospital lighting, there was no significant reduction in your post-IL-6 to pre-IL-6. The same thing with regards to IL-10. The ratio stayed at 1. But if you were exposed to blue light, IL-6 went down, and so did IL-10. Now, I also don't want this talk to be just about immunity, right? We're surgeons, we're anesthesiologists. I want this to also be about things that are relevant to us, like thrombosis and hemostasis. And so we recently did some work and identified that all of the factors within the coagulation cascade exhibit a circadian rhythmicity, peaking in the morning for us, waning in the evening when that risk of bleeding goes away. Fibrinolytic activity does the same, but in opposite. So fibrinolysis goes down during the morning, and then, it goes down during the morning and then begins to increase in the evening. So we took those same individuals that were exposed to an hour of blood, and we decided to test a bunch of parameters associated with coagulation or fibrinolysis. And what you see is shown here. That if you're exposed to a short, acute blue light, there's this augmentation in ionized calcium concentration that does not occur with just the office lighting. Good, right? Calcium is very, very important to that intrinsic cascade. We don't see any differences in cortisol. In both ambient light and blue light, cortisol continues to go down towards its morning nadir, right? We see an augmentation in the extrinsic cascade of coagulation after blue light, but not with ambient white light. These two are related because calcium is more important for that extrinsic tissue factor pathway. Your fibrinolytic activity continues to, increase if you're exposed to ambient light during the evening, which is what we would expect. But acutely exposing you to blue light halts that activity and makes you a little bit more clotty. Now, I don't want this also to be just about coagulation and just about immunity, right? There's sometimes some of these things are bad for us, clotting being one. So sometimes we want to induce clot formation. I'm a trauma surgeon at night. But once I've got all those holes plugged up, the big risk for me now is DVT. In fact, the leading cause of preventable hospital death is venous thromboembolism. So we decided to ask whether or not taking blue light away might be a means by which we can facilitate prophylaxis for venous thromboembolism. I was still at Pittsburgh at the time, and I was working with an individual by the name of Matthew Neal, who's very, very much of a hematologist and blood biologist, and Elizabeth Androska. And what we decided to do was to test blue and red light in mice in a model in which we ligate the inferior vena cava. So you ligate the inferior vena cava in a clot form. And we took these mice and we put them in blue, red, or ambient white light the day before. And what you see was that if they live in red light, they make almost no clot, versus animals in ambient or animals in blue that make this nice big pump clot. We've all gone on to tease out the mechanism requires the same pathway, an optic pathway that ultimately is autonomically innervated. Well, with that, I'm going to conclude. I hope that I have convinced you maybe that the spectrum of light is a determinant of mammalian biology. I do think that light therapy and bringing circadian therapy to the bedside is on the horizon and underutilized. As I'm sure all of you can appreciate, no one does anything alone anymore. Science, medicine, teaching are all team sports. This is the team that I've been or had the good fortune of being a player with. And for that, I thank you for your attention and are happy to field any questions. Do I just point? Okay. Yeah. Great. So that's a great question. I don't know. I honestly don't. I certainly can hypothesize how it would be, right? But I don't know. I really, really don't. Yeah. 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 I did not present any of the data. We're just about to finish a small NCT trial looking at blue light in ICU patients that are critically ill from sepsis. We've enrolled 26 and we need 30. It is a 3-day exposure to a 12-hour photo period. So these patients starting at 7 a.m. get 4 hours of bright, bright blue. It transitions then to 6 hours of bright, bright white. Then it goes to the regular sort of dusk type of light of the ICU. And then at 7 p.m., they put on amber goggles that block the blue light, right? Because the light never go off in the ICU, but I wanted to take away the blue spectrum at night so they truly had a dark light. We see the exact same changes to autonomic activity in patients that are sedated and mechanically ventilated. And I will tell you that there are 4 groups: pneumonia, necrotizing soft tissue infections, intra-abdominal sepsis, and septic joint. And 80% of those individuals are ventilated and sedated. We see the exact same dominance of parasympathetic tone and withdrawal of sympathetic tone if the subject is randomized to blue light and not if the subject is randomized to ambient white light. We're undergoing the omics and things of that nature. One other thing that we have seen, you know how melatonin sort of is cast into the wind in critical illness. There is no circadian oscillation of melatonin anymore. But we have found, because we sample these individuals 3 times a day for the first 3 days, that with the blue light, there is a cycling of melatonin again that starts up by day 3 and does not occur if they are exposed to ambient light. So you don't need your eyes really open much to get that type of effect. I don't know what period they're actually seeing the blue light. Everybody undergoes a sedation vacation and a spontaneous breathing trial. So I know that their eyes are open at some point, and that almost always occurs in the morning. We do try to target a reasonable RAS. The ideal patient actually is awake and compliant with the ventilator. So that's a long-winded answer for yes, it still works. Yeah. 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 Yeah, no, great question. It appears to be that with removal of the long wavelength reds is also beneficial, right? So if you look at some of the prior work that we've done and others, depending upon the outcome, it tends to be this latter effect. If you looked at that last slide with regard to the clot for the red mouse was really, really small. For the animal exposed to ambient light, right? It's thinner, but still large. And then when you get to the blue mouse, it's really, really plump. We believe that that effect is less due to platelets and coagulation and more due to immunothrombosis. So the degree to which the immune system's coming into the clot to modify it, right? But in answer to your question, I believe that the removal of the log also provides an advantage that I haven't teased out. Yes, sir. So there's no doubt you should not be seeing blue light in the, yeah, absolutely. And that gets into that importance of the dark phase, right? Which is actually nothing. One of the nice things about red light, and why we use it in photography and we use it in labs and stuff like that, is because of the thought that, well, there's no blue light in it, right? So we shouldn't necessarily have circadian rhythms being entrained. That's true for the most part. But we do know that red light, even in rodents, still enables them to have a more of an activity phase than in its absence. So I think that even the presence of red light is probably not good, and that you want it to be pitch dark at night with nothing. What are you doing?
We're gonna have to get to that bar in a second. I have one question too before you all leave.
Do it.
I work in the CTICU. One of my pet peeves in life is like where these people are doing fine and they go to sleep and their brain turns off and everything turns off and then they get put on vasopressors for like 12 hours. And they wake up and they're fine and everything comes off. It's like they're hypotensive requiring vasopressors at night and then they're hypertensive during the day and they stay in the ICU for like 3 extra days for that.
Yep.
Is that the same at WashU and Pitt? Is that everywhere? Is that just at UVA?
No. There's vasopressin is raining from the sprinkler system at Washington University. No, the exact same thing. So no,
Okay.
it's not. It's unique. Lots of unique things.
Well, thank you for coming. This is a gift from the anesthesia and
You're
surgery
welcome.
departments. And the main thing for me is like, this is fascinating, but the idea of thinking differently and pursuing it. Like, I think a lot of people probably did think you were crazy, but that
I am crazy.
you keep adding up this different data, especially with like the ocular lens data is absolutely fascinating. And so
So you have to pay attention to his work, right? So it's intimately related to this, but from a completely different mechanism. As I said before, and I don't know the mechanisms as well as Dr. Thiele does, that as you get shorter and shorter and shorter in the wavelength, there's this increase in energy. It's not UV, but it's this increase in energy. And he's essentially pioneering this. Do I call it phototoxicity?
we don't have a name for it yet, but we're trying to kill
Finally
bacteria.
talk about this?
Yeah, yes,
Okay,
yes,
I
you are.
want to make
Yeah.
sure.
Yeah.
All of a sudden the clock starts ticking for IP. So that you can use this blue light in a non-UV way to essentially eradicate bacteria, like log fold after log fold after log fold reduction. And you can then begin to dream about the translation of that to being toxic to other things that we might want to kill. Right now, I'm shining blue light on the patient in the ICU, and some of the nurses were complaining because they really would like it to be a regular light. So we've generated this nice canopy that just goes around the patient's eyes now, right? That's great, but I miss out on potentially being able to apply short wavelength blue light to the entire ICU room, and in a very non-toxic way, keep bacterial burden down throughout the entire ICU. For things that are multi-drug resistant, this will be even more relevant. It's going to be a non-antimicrobial therapy to keep the bacterial load.
All right.
Well, thank you.
So
Thank
much.
you so much. Yeah, appreciate it. We should do that.
Oh yeah. I mean, the word.
No, go. Was it good? Yeah, absolutely.